Let me know when I can start.
Yes, you can begin.
Okay. Good evening, everyone. Thank you for joining. Thank you for joining us this evening to discuss Primary Healthcare Act. This is a series of the UHC Keme has been conducting in collaboration with Kenyatta. And today we'll be discussing the Primary Healthcare Act. I'd also take this chance to welcome you to next Monday's discussion, which will be on the Facility Improvement Fund. I am very impressed by the numbers that are here and the representation from different countries and even counties. I think currently we are at 839, so that's a really, really good attendance. And we hope to learn more about primary healthcare, the Act, and how we as different cadres of healthcare workers can plug in and support, or how we will be supported. I'll take this chance also to introduce our speakers today. We have Mr. Kenneth Otieno Mwanthi, who will be our first speaker. He's a community health services focal person. And then we have Dr. Oda Mirimo. I'll be introducing them more when it's their time to speak, who is the head of primary healthcare division, primary healthcare and family health division for Nairobi County. Dr. Maureen Kimani, who is the head for the division of community health in the Ministry of Health, and Dr. Salim, who is head the division of primary healthcare, also in the Ministry of Health. So to begin our conversation this evening, we'll just jump straight to our presenters. We'll begin with Mr. Kenneth, Mr. Mwanthi, who is a community health services focal person. His expertise is in community health mobilization, community health workers, and everything that goes on with community health workers and the functions that they perform in the grassroots. So I'll take this opportunity to welcome him and for him to give us his views and his thoughts in matters community health. How does community health, for example, interface with primary health care? What's the role of community health workers? What are the current gaps that he's seen in his profession and in his expertise? And how does the Primary Healthcare Act support community healthcare workers, or how rather would he, as a community health focused person, sorry, somebody's saying the volume is low. Let me just adjust my volume. Or Nelson, you can help with that. And how can he, as an expert, support also in the Primary Healthcare Act? Welcome, Mr. Omondi.
Good evening, colleagues. Good evening.
Good evening.
Am I audible?
Yes, you're very clear.
Very clear, okay. I'm happy to join this discussion because I've been in this coordinating community health services for quite some time, since the inception of community health strategy in 2006. We are one of the people who started coordinating these community health services. I'm also happy to say that we have the Act, the Primary Healthcare Act, which is going to guide the implementation of some of the services at level 1. But before we start our discussion, we should revise a bit and look at the meaning of who is a community health promoter. This name was given just some time back. We have migrated from community health workers to community health volunteers. Now we call them the community health promoters, which are key pillars in implementing primary healthcare at level 1. Because if you look at service provision at level 1, we have the disease prevention and health promotion, which is conducted by this cadre. And if we can remind ourselves of who a community health promoter is, as is indicated in the Primary Healthcare Act, this is a person a member of the community is selected by the residents and appointed by the county and is trained to provide community health services at the household level. We are going to look at what are these services. And they operate within a community unit. A community unit is just administrative. It's just, if you look at the local administration, is the equivalent of a sub-location. So in terms of primary health care, the community health care services which the CHPs provide include things like health education and promotion, the disease prevention and control, to reduce morbidity, disability, and mortality. We have family planning, environmental health hygiene in the community, first aid and treatment of minor illnesses, because they don't deal with the complicated illness. That is their mandate is to refer. If they cannot, any services which they cannot handle the community, they refer. Community-based surveillance, the psychosocial support, rehabilitation and palliative care in the community. Referrals is key. They refer for various services to the nearest, the link facility, which is the nearest to them, and then manage health data in the community, because everything you do, you have to produce data to support what you're doing. So in the context of primary healthcare, I think some of these things are mentioned in the Primary Healthcare Act of 2023. So in the context of the primary, if you look at the definition of the primary healthcare, there's one part which I need to put more emphasis, the universally accessible issues to do with the accessibility to individuals and families in the community through their full participation. We expect the CHPs to be providing some information to the community members pertaining to community health services, so that they fully understand at this level what do we need in terms of health services, what are our priorities in terms of disease prevention and health promotion and such. So I think we are together. Hello?
Yes, we are.
Yeah. So in looking into the context of the roles of CHPs, in some of the roles of CHPs, I've mentioned some, and they also bridge the health system and communities. You know, the linkages between level 1 and the facilities. I've talked about health education, identifying and referral of health problems to appropriate primary health care facilities. There's issues to do with community disease surveillance, identification of health needs, and those are some of the things they are doing. So when you look at this, the roles of CHPs, they also need technical expertise, because if I can go back, if you talk of health education and promotion, what do you mean? It's not just a statement on its own like that. We need the community health volunteers to be imparted with knowledge on issues to do with health education, and then how they can do health promotion at the community level. When you talk of disease prevention, we have several diseases. There are so many diseases. How can they be guided in the control of each and specific disease in case of an outbreak? Take for example, malaria. They need some information about malaria so that they can be doing health education and promotion at the community level. Family health services in the community, environmental health. This is where we need the expertise of the public health officers to join with their counterpart, the community health assistants, because the public health are well trained on issues to do with environmental health and hygiene. And if you talk about the community-based surveillance, what do they need? What do they need in case of, like, for example, I can remember our CHPs did well through the support of public health officers on COVID-19. They were really on time on identifications of the cases in the community. We have issues to do with referrals and manage data as data. If you talk of management of data at the community level, what kind of data are we talking about up here? So in implementation of this primary healthcare, we need a blend of cadres so that they can help us provide services to the community. Are we together?
Yes, we are. You can put your
Hello,
question.
Dr.
Yes, we are. Can you hear me?
Yeah, okay.
Yes, you can put your
Yes,
questions
I'm
in the
getting you
chat.
now.
Thank you.
Yeah, they can put their question on the chat so that, we are given limited time. So if you talk of the gaps, which I think is the major focus of our discussion here, and then we link the gaps to the Primary Healthcare Act. One of the serious problems is lack of resources, supplies, and equipment, which I think the government has tried now. As we speak, several countries, the community health promoters were provided with the kits. But one other issues is the kits. If you look at that kit, whatever it contains are expensive, and they also need a lot of technical know-how on how to operate some of those kits. For example, the BP machine, the glucometer, the use of work tapes, both adults and children. We have the scales. So some of these things need a lot of technical know-how to operate. Otherwise, we don't want to repeat mistakes which were done sometimes back. So lack of resources, supplies, and equipment were major issues. And then I've said about in lack of skills and knowledge of handling some of this equipment is another major issue. And then we talk of limited recognition. We find that some of us health workers have not appreciated the existence of community health volunteers, even in one lake facility. Yeah, they will say these people are not well trained. Even if they refer clients to the facility, they are not received well. So those are the issues we need to be addressing. We also lack of resources to train CHPs on technical modules. Apart from the basic modules, we have the technical modules like family planning, the reproductive health, the sanitation issues, the indoor air pollution. Those technical modules, I'm happy the Department of Community Health at national level produce those technical modules with a purpose. So we need resources to train the CHPs of those technical modules to help them implement the primary health care as required. We also, at some point, we lack support supervision from the health system. This I can say is that if you look at this, some of the employment taking place in our county, the employment of CHARs and the community health officers, it doesn't augur well within the existing system. So if you look at the cadres, the qualification, I mean, of some of these people who are supposed to be supervising the CHPs, the qualifications are outside the Ministry of Health mandate. I think that one also should be looked into. We go back to the scheme of service. We look at who is supposed to be employed as a community health officers to offer the technical expertise to community health promoters and support supervision. And then the financing bit of community health services. Community health services is expensive. One county, like for example, my county, you have like 3,000 CHPs. In terms of motivating the CHPs and looking at the equipment and supplies, needs a lot of efforts and needs a lot of funding. And then we also have the weak linkages between between community health and public health systems. If you look at what is required, the services offered by CHPs at level 1, the same services are being offered by our team of public health officers. So if we can link the two departments together, they fall within one department. I can say we can go far instead of separating community health from public health. That's why I'm saying the linking between the two systems can help us achieve our goals in primary healthcare. We have also the training of all community health promoters on technical models, that one I've said. And we should also have the uniform motivation of all CHPs in all counties. We don't want a situation where, this is my opinion, one county is offering 5,000, one is offering 3,000, the other is 2,500. No, they also, the CHPs are also communicating their colleagues all over. Yeah. So, how much are you being paid for stipend? 5,000. How much are you being paid for stipend in your county? 3,000. I think we should harmonize this. And then restocking of commodities for provision of level 1 services. Like now, each and every CHP has a kit. They were given drug plus a kit. So the next question is, after stock out of these drugs, who is going to supply the next batch of the same? And then issues to do incorporating the digital technology into service delivery and data collection, which I think all of the CHVs, the national government provided the funds, which I think is okay. They provided the national, they also took part in the training of all cadres, all workforce within the community health system on EACHs, which I think is going on well. So the next question we are going to ask ourselves, who is going to give the bandwidth for the CHPs in running their daily to-day activities? We can also do resource mapping and identification, resource mapping and who is supposed to provide which resource. If you look at how the things operate now, a partner comes, a partner is specific with their programs, and they don't implement the programs in the entire sub-county. So one part of sub-county benefits, the other part of sub-county does not benefit in terms of the requirements of partners with their activities. And I think in this era of primary healthcare, which is being introduced, we should revise the number of households for CHP. Instead of 100, I think it should be downsized to 50. And then I'm happy the national government, the policies you are developing are very good. But the next question is, how do we now implement the policies? For example, I'm seeing Dr. Felix from Policy Advocacy Committee. You can help us on this. This is implementation of policies like the Kenya Community Health Strategy, that is 2020 to 25, and the Kenya Community Health Policy 2020-2030. And now we have the Primary Health Care Services Bill of 2023. How best can we implement these policies to succeed? And then addressing the human resource gaps for both public health and community health services, because both of them are, their mandate is the same: disease prevention, health promotion, and disease control. And then we also have motivation and retention of community health workforce. How do we motivate CHP? And how do we motivate the supervisors of CHPs so that they work well? And then we have mobilization of political goodwill to offer support for community health. Without the political goodwill of the county, we will never achieve our efforts. And then the last one is reworking on the competency requirements for recruiting CHPs. The world is growing. Like now we are in the digital world. If you look at some of our CHPs, some cannot even operate the mobile phones. It is giving us a hell of a problem. So the national government are requesting you to come up with how we can the recruitment bit of community health promoters. Otherwise, we are happy. There's things which have worked well, like, for example, the involvement of CHPs in research. KEMRI is doing a lot of research using CHPs as part of the research, implementation research. Like in one study, the member study, the CHPs are doing pregnancy tests and they're doing consenting, which I think is okay. And then our partners are capacity building of CHPs by partners. This is well done by our health partners. And lastly, the monthly DQAs, which is being done for specific counties. I think if we can address all those issues I've mentioned, we can as well implement the Primary Healthcare Act to its successful end. Otherwise, thank you.
Thank you, Mr. Mwendi, for that very precise and insightful presentation. When people were introducing themselves earlier in the chat, I saw that there are quite a number of community health promoters. Somebody even introduced themselves as a super CHP. And I think what you mentioned, just to summarize, for people who may have just joined, you've talked to us about the functions of a community health promoter, the important work they do at promoting healthcare at the household level, and some of the needs that have come out to me that have struck me is what when you speak about the kits and that they are important, yes, but they need a technical know-how expertise, for example, glucometers. And I wondered if the strips are finished, where do community health workers get the next supplies? I have heard about the financing and rather remuneration, the disparity in pay in the scheme of service. And I know for a long time, community health promoters have not been paid. And so there are a number of questions in the chat. So perhaps I'd ask my fellow panelists, if you're able to answer some of the questions in the chats, you are able to type, that would go a long way. There are questions that have been asked and I'll have them answered after the next presentation with Dr. Kimani, because her presentation may answer some of them. So Dr. Kimani, as you present, something that has come severally in the chat is the question on remuneration. How the Act stipulates, does the Act stipulate how they'll be paid? And will there be controls at the county level? Because currently the counties are sort of the custodians of healthcare. About quality services, some people have asked about quality. How do we ascertain that a community health promoter is qualified for the roles that they are doing and they're giving good advice and taking good care? So you can have this in mind as you present. Nelson, you can put up the presentation from Dr. Maureen as I read her bio. Dr. Maureen Kimani is a medical doctor and a community health system specialist with 15 plus years of extensive experience in the public sector. Currently, she's the head division of community health at the Ministry of Health Kenya. She led the development of community health policy, guidelines and standards, and leads strategic partnerships with various stakeholders to strengthen community health systems. She co-led the development of the Primary Healthcare Act 2023 and the Primary Healthcare Fund in the Social Health Insurance Act 2023. She played a strategic role at the National COVID-19 Task Force as the team leader of the Community Engagement Work Stream and ensured that community health workers were protected and facilitated to work during the pandemic. She also coordinated the continuity of community health services during the lockdown and ensured that community health workers were facilitated to deliver essential health services to their communities. She also provided insight in the introduction and rollout of differentiated care model in the HIV treatment plan. Dr. Arias, you make your presentation. There's also been a number of questions about community healthcare workers in terms of different partners, as Mr. Mondi has said, different partners wanting to do different things. So if a partner is interested, a health partner is interested in HIV, they'd only support the community workers in HIV work rather than malaria, for example. So who not owns, but who does the community healthcare worker report to, or rather whose health agenda? Is it the counties? Is it the countries, or is it the partner, whoever is remunerating them at the time? Welcome, Daktari.
Thank you so much, Phyllis, and a big thank you to Mr. Kenneth. I think he really brought out the issues in the ground. You know, many times we are seated in boardrooms developing some of these things, and it's really great to hear some of his reflections and his very good knowledge of our national documents that guide implementation of community health services in the country. So really, really excited about that first panelist reflection on community health. So before I just give highlights on what we have included in the Act, I'll just give a background and then I'll move into the presentation. So so the community health services began about 2006 in the country. And this was as a result of studies that had been done and shown that in a few areas where community health workers, remember, right from Alma-Ata, we had primary health care. Different initiatives had been done, including the Bamako initiatives and others that really tried to engage communities in their own health. Like, the health does not start in the hospital. Health actually starts at home. So the decisions that people make about the food they eat, where the hand washing practices they have, the kind of sanitation facilities, all that have a huge impact on their health. And of course, it's important that as a government, we don't just focus on curative services, but rather, and everything starting from facility level, but rather going back to the communities and trying to ensure that as many people as possible are kept healthy. We know that currently we have a double burden of disease. We are still struggling with diarrheal diseases, for example, and of course, right now, an increasing burden of non-communicable diseases, and really trying to, and when you look at our disease burden in the country, you note that a lot of the diseases we have are actually preventable diseases. So, and that's why the entire idea of really engaging communities, coming up with all these strategic documents, the policy documents, including this even within our Kenya Health Act, in the Kenya Health Policy, all began. And it's been a journey for us to get to 2023, where we actually have now a legal instrument that really institutionalizes the role of communities in health. So just to say that, and to say that community health promoters are just the community members who we are supposed to involve, only that now we pick a few of them and probably give them more information and train them on how to be able to go and translate that information back to their communities, to their neighbors, to their friends, to people who they do social events with, they go to the same church, they are involved in many social activities together. And probably that would really help in us reversing the trends or some of the things we see, because a lot of them would now be able to adopt healthier behaviors, because they can see everybody in my neighborhood has adopted this healthy behavior, and there is somebody who is your neighbor coming to your doorstep every day at the times when you're not sick to actually tell you about health. So that's the whole idea. And so these are not health professionals, they're just community members, and we are just again, going back to Almata, the bigger theme was how do we engage communities in health, and for them to understand that health begins at home, that their day-to-day actions promote health or cause the diseases that they have. So I think that's the whole idea. So we've come a long way. In 2020, we got our first ever community health policy. In the same year, we had our third edition of our strategy. The ministry always had a strategy since 2006. And because of that, we have had many wins, but we are still a long way to go. And therefore, we really needed this legal framework to make sure that now the CHPs can be able to do their work without any major barriers, but then we can also strengthen the system now that the legal instrument is in place. So with those few remarks, Philip, I would like to go through the slides just to highlight some of the things that we have included in the Act under the section on primary healthcare, on community health services. So this, the PHC Act 2023 clearly define some of the things that I have outlined here. So we have a whole section that talks about what are these community healthcare services we are talking about. We know there are services at facility level, which are still preventive, promotive, but then what are these community healthcare services that healthcare professionals and community health promoters can be able to do at community level? Then all are that are allowable in the community space. And of course, we know that community is the level one of our health system. That's already well entrenched in the Health Act 2017. So no issues around that. So then, of course, we also guided on how the CHP should be recruited. Again, I said these are not health professionals, so we just follow the same guidelines that we've had before. The functions of a CHP. So there are many community healthcare services, but what can a CHP be able to do within that? So some of these community healthcare services, as you can see here, are issues around health education and promotion. Again, this is a function that also happens at the facility, but there are specific things that we can be able to train our CHPs to do around this. Then disease prevention and control. There are issues of family health services in the community, environmental health and hygiene, provide first aid and treatment of many ailments and illnesses and injuries at the community. Then community-based surveillance, just to ensure that we are reporting any incidences in the community where there are so many animals have died, or maybe there's a death in the community. Anything that happens in the community, they're able to report that, and the surveillance team within the county or the sub-county can be able to go and do their own investigations. Then there's psychosocial support, rehabilitation, and palliative care, which can be done at the community. Define the Community Health Act. And then they're also expected to manage health data in the community, and more importantly, referrals, because again, community health services also is much about creating awareness and also creating demand for healthcare services. So we have good uptake of maybe screening services and other primary healthcare services. Next. So under recruitment, we have clearly stipulated in the Act that the community health promoters shall be selected by the community where they live and appointed by the county government. And the selection is that they must be a citizen of Kenya, they're above 18 years and of sound mind, they're responsible and respected member of their communities, they understand the role of a community health promoter, that is very important. They are a resident in that community for a duration of not less than 5 years. 5 years. They're literate and can read and write. They are not disqualified for appointment to office. Next. So then again, it also now clearly stipulates the the roles and responsibilities or the functions of a CHP. What can they do? I know previously, prior to this act, I know there's been a lot of task shifting to the CHPs, and so this act now really tries to show what can they do, what are they allowed to do, because within this act there are also offenses and penalties if they do anything outside the scope of what they're allowed. So we have here, they are to sensitize the community on the importance of healthy lifestyle and quality health services. And then they are to provide community surveillance and report. They're like our early warning system within the health system. They are to enroll and monitor health status of members of households assigned to them. Each community health promoter is usually assigned about 100 homes, which are within their area of residence. So it's usually within your village, because that's the kind of population, about 500 people that they oversight. And then they can keep and maintain a record of members in all the household assigned to them. They monitor the rehabilitation and integration of persons who require such services in the community. Next. They also provide appropriate health advice to an assigned household in a language that the members of the household can understand. And that's why it's important that they understand the local language. So once they have been trained, then that's when they'll be able to offer this service. So anytime they're recruited, they need to be trained so that now they can be able to give appropriate sanitation and hygiene techniques, including household water treatment, good nutrition, maternal and postnatal care, including advice on breastfeeding, immunization, child health care and family planning, prevention, transmission, and management of communicable disease, and also prevention and management of non-communicable diseases. Next. They also render first aid services to the assigned household, and where necessary, they make referrals to the linked health facility. So referrals is one of the other key mandates. So they create awareness, they do first aid if they needed to do any first aid, and then the important thing, they have been informed or taught on how to make appropriate referrals to the linked health facility. Then they provide support to their assigned households on quality family-based care and support. And then, of course, they obviously every month submit a report. But as a ministry, we've already rolled out the electronic community health information system, which now is the digital tool that they're using to collect this data and submit it to the MOH databases. Then they also report incidences of side effects. So if they know that one of their household member is taking any kind of drug, then they would also educate the person. If they feel anything that is not usual, then they need to report that immediately and get back for further care. And then, of course, they perform any other duties that the CC health may give them, or any other thing that has been put in the county legislation. Next. Then the act is also very clear on how the CHPs should conduct, so that we don't create quacks in the community. One, they should be ethical. They should inform the household of the use for which the information shall be put. Any health information that they seek from the household, they need to inform, they need to get some verbal consent. And of course, they must practice high levels of confidentiality at all times. And then ensure that any data they collect is accurate, and they transmit the information immediately now that they have the funds, or within the day, if maybe they're working offline and they didn't have data bundles at that time. And then also ensure access to personal data by persons to which the data relates to is in accordance with the Data Protection Act. So again, this is something that we are really going to be serious about. And I think the Digital Health Act really talks about it, that anybody handling health data is a data processor, and therefore they'll have to align to specific guidelines that the data commissioner has outlined for all data processors. And of course, there are penalties if you don't align to those guidelines. Next. Then, of course, we also talk about that there should be a register of the CHPs. And this is very important so that you don't get rogue community members becoming CHPs. So you need to know to have their bio data. Then you need to have the information on the link facility which they report to, and the link facility in charge should have very good rapport and know all the CHPs who are working within their catchment population. And then, of course, training is critical. I think Mr. Kenneth talked about it, that we have huge disparities. There are some CHPs who are very well trained, but in other areas, they are not so well trained. Remember, the national government support is going to all CHPs in all 57 counties. So all of them need to have the same standard as stipulated in their CHP training manual, which the ministry has developed, and given to the counties to do the training and any other. And then it should also show anybody who has been registered, and then, of course, any other information that the county they want to know about the CHP. So this is a registry that all counties have already begun developing and have developed. And of course, it keeps on getting updated with the county, the CHP didn't behave well, or the county, maybe they are no longer able to perform their duties, especially now that we are moving to digital space, and a lot of them may not, some of them may not be able to get into that space because of age or any other issues. Then they are able to replace those and update their registry. So we already have a registry by each county, and of course, a registry at the national level of all the CHPs. Maybe here I'll pause and say that in the most of the CHPs, we find them mainly very urban, in the rural and informal settlements. Those are almost 100% covered. Where we are still thinking about a model that can work is within the estates, the middle class, and upper end areas. So that's the areas that you really are thinking about. So of course, we need to motivate them, because I mean, they are utilizing their services, they are supporting our communities to be more healthier. Then the act is very clear that the county government shall allocate resources to ensure this training, this provision of working tools. I've had some questions around how will they get the kits, how will they get the supply for the strips, for batteries, and those other things. Those should be included within the county budget. And then the cost stipend and supervision. But we also know that the national government has also gotten into an agreement with the counties to do this for a period of time. And then this is ultimately a county function. And we're looking at the different legislations that we're doing and how, for example, the primary healthcare fund can at least support in ensuring that the link facilities are able to quantify all commodities that are used at the community level and include them as they are ordering for their own commodities. Of course, once some of these legislations are put into practice, like the FIF and the primary healthcare fund and others. Next. So we also have issues around their area of work. They work within what we call community health units. And the Act also clearly stipulates what these are, and the counties are supposed to establish the community health units, and the catchment population is outlined, and of course, what is the population that is covered. And of course, this can vary from different geographies. For example, in the north, where the population is quite sparse, this population may go down. But then in very highly dense areas, maybe like we are talking about an informal settlement, people staying in a geography of 5,000, maybe in a very small area. So that again, the counties can be able to agree on how to delineate the community health units. Next.
Dr. kindly wrap up.
Okay, so I think just go to the end to the penalties. I think I'll not talk about the community health committees. Yes. So under the penalties, it was very clear that the community health promoter shall not conduct any procedure that is beyond their training and approved scope of work. They shall not administer to a person medication that is not authorized by clinical guidelines under this act or any other applicable law. They will not conduct any deliveries for pregnant women. They will not handle with negligence any property given to them, or use the kits that we have given them for purposes other than delivery of community health services, solicit financial or other rewards for personal gain from the community. Next. And then falsify records or withdraw services because of whatever reason from any community member. And then they should not engage in other activities that may conflict with their duties. And of course, issues around confidentiality. And it's clear in the law that anybody who commits any of these offenses, any CHP who commits any of these offenses will be individually liable and will face, of course, the law. But we don't want to get to this place. So as health workers, as a different cadres working within the primary health care space, the MDTs, the in charges of the linked facilities and other health workers, it's really our mandate to really support, mentor, supervise, coach these CHP so that they're able to do the right thing at the right time, and of course refer as necessary, just as we have taught them. So I submit back to you, Dr.
Thank you, Dr. Kimani. I see a lot of reactions have come up, thumbs up, and also a number of questions. You've answered a number of questions that were already in the chats in the course of your presentation. Two stand out that I'd like to ask, one to you and one to Mr. Omondi. Somebody has asked on data management, because this is something you've spoken about a lot and also Mr. Kenneth spoke about. So this question to Dr. Kimani. Are the community health promoters using the data that they collect? Are they reporting it, and how is it integrated into the DHIS and later into the national system? Or is this data just resident in the county? And to Mr. Kenneth, somebody has asked, why have we overburdened a community health promoter with such roles and functions which even a multidisciplinary team in a facility can't handle? So, Mr. Kenneth, do you think the community health promoters are overburdened by the long list of responsibilities that we've seen? You
That's
can
why,
go
okay,
first.
Doc, that's why I was saying, with that bigger role, the number of households will be reduced. So 100 for the role they are performing. And then again, the partners are also coming with the activities. They want the CHPs to be involved in those activities. Yeah, I agree. At some point, we overburden the CHPs, given that they are not qualified health care workers. Yeah, if you look at the job description, there's a lot. That's why I also said the people who are supervising the CHPs to also be people who are competent and know what they're supposed to do in terms of addressing health services at the community level.
Okay, thank you. Dr. Kimani, also make a comment on the other health partners other than the counties and the national health and the national system, who also have the demand for CHPs. Who should CHPs answer to? If you have 2 or 3 bosses, it becomes hard. So especially in conflict of interest. So you can answer those, and then we'll proceed to the primary healthcare discussion on more.
Thank you. So in regards to the first question, which was around the electronic community health information system, so the ministry developed a mobile application And basically, this is just moving away from our paper tools. We had many, almost 6 MOH registers that CHPs were using. And so we just moved all those many tools into a mobile application where the CHP will just enter the data. The data, so long as they are within an area with the network or Wi-Fi or they are using their data bundles, then that information is submitted and gets to the MOH data center. So at the end of every month, there's a monthly summary tool for all community health data, which we've had for several years now, which data used to be submitted to KHIS. So for now that we have this mobile application, at the end of the month, it generates that MOH reporting tool. It's called the MOH 515. And then this tool is now validated by the community health unit at the community health unit level by the supervisor, who can be the CHU, the CHA, or the CHO, and then now submitted to the next level. I mean, validated and now approved within the system. Then the sub-county team also approves, and then the data gets onto KHIS. So once that process is done, then of course the country fully owns the data, they have looked at the data, and of course there are different dashboards that have been created to actually help the community health units to be able to look at that data and of course use that data. So they're not just collecting for the sake of collecting, but they're collecting that data so that they can use it for their own planning. They can plan their outreaches, they can plan their community dialogue days. If there's an emerging issue within the community where they need to meet the community members and discuss, they can they can even look for resources based on where they see some of the major gaps. So that data is supposed to help them, and therefore the community health unit has access to that data. The sub-county team have dashboards to help them, and they can do even further analysis because it's their data, and also at the county. Then, of course, at the national level, we're able to view what everybody is doing, and of course, that we can be able to do so much more in terms of using that data for planning, for policy, for resource allocation, and everything else. So I think the other question you asked was it regarding the many partners that we have. Remember, before we got the law, there were CHPs verticalization was at the community level. You see the way there's some vertical programs within health facilities, like the CCC is separate, the TB clinic is separate, things are not integrated. That's the same thing that was happening. So there were lots of CHVs who are reporting to the HIV partners or TB partners with all sorts of names and all that. And there were some areas where CHVs were all integrated. So in our current scenario, and if we look at the act, the CHP is kind of a staff of the county government. And therefore, when they go to the household, they cannot just go there and just follow up a defaulter, a TB defaulter, or maybe just do a CRM support. They have to do everything. They have to look at nutrition, they have to look at wash, and they have to report on everything, because at the end of the month, some of the performance measurement for them is, have they done everything that they were supposed to do? So you look at the data that community health unit has generated, it will tell you why your CHP is working or they are not working. And also the itches is a very good tool because it's like a service delivery tool. It helps them. It even has messages inside there. They can alert. It has alerting something is an emergency, someone needs to go to the facility. It has all those, so they can be able to refer immediately, give key messages which they can immediately give to the health worker just based on some of the data they have collected. So really, we are really helping or supporting them to be able to make those community level decisions with a very simple tool which has undergone lots of testing. We have used a human-centered design to make sure that the tool is actually good for the user. So I think that's all I'll say for now. Thank you so much.
Thank you, Daktari. I'll ask, we started a bit late, almost 30 minutes late, so I ask that we will go over by a few minutes. So we still have two speakers to go. Our next speaker, I think the slide is already on the screen, is Dr. Oda Koni. Dr. Oda Koni Mirimo is a highly skilled and dedicated family health physician with over 7 years of experience in Kenya and Cuba's community health and primary health care services. She holds a master's in family medicine and an MBCHB from University of Nairobi. Currently, she's the head of primary healthcare division and family health division in Nairobi County. She'll be giving a short presentation on the topic, exploring primary healthcare in the counties, unveiling its components, roles, and collaborative strategies for healthcare professionals. So in a nutshell, what does primary healthcare look like in the counties? And how do we as healthcare workers plug in? Welcome, Dr. Ari.
Thank you so much, Phyllis, for the introduction, and I'll just get into it because you are a few minutes late. We will begin by the definition of primary healthcare. And based on the Alma Mater Declaration of the 1978, primary healthcare is defined as essential healthcare based on practical, scientifically sound and socially acceptable methods and technology made universally accessible to the individuals and families in the community through their full participation and at cost that the community and the country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. Another definition that I want us to know today is about the primary healthcare workforce, and this includes both the healthcare providers and the community health promoters. A bit of evolution of primary healthcare in Kenya after the 1978 Alma Mater Declaration. Kenya adopted the primary healthcare, and it has developed various policies and strategies to support this. I will highlight several because the speakers who have gone before me have highlighted some of them. So I'll focus on the 2014 when we had the Kenya Health Policy, the Kenya Health Sector Strategic Investment Plan, where primary healthcare is supported. In 2020, we had the Kenya Health Strategic Framework 2020-2024, the Kenya Community Health Strategy that is running up to 2025, the Kenya Community Health Policy that is running from 2020 to 2030. And in 2021, we did have the Kenya Primary Healthcare Network Guidelines. And in 2023, there was political commitment to primary healthcare by the current government, which in my slide, you'll see referred to as the beta priorities. Why primary healthcare? In the year 2018, UHC was piloted in 5 counties across the country, and it was noted that people were still going to higher level health facilities to obtain primary healthcare services. Health services for the community were not available at the point of need. There were weak linkage between primary healthcare facilities and the community, and the trust within primary healthcare service delivery was at a low level. Thus, the primary healthcare was proposed as the gateway to attaining universal health coverage. And that is why we have the Kenya Primary Healthcare Strategic Framework to support this. After development of the Primary Healthcare Strategic Framework, the implementation of the primary healthcare is through the primary care networks. And primary care networks is what we are seeing on the screen. This is a network composed of the community health units we have talked about the community health promoters. They are not working alone. They are working with the multidisciplinary team. These community health units are linked to the health facilities, that is the level 2 and the level 3s, and then they're linked to the level 4, which is the hub referral facility. So the first level of healthcare in the primary care network is the community health unit, where one unit has 10 community health promoters. And these community health promoters are usually governed by a community health assistant known as the chair. So in this primary care network in our counties, we are going to hear a lot of hub, which is the level 4. We are going to hear about the spokes, the level 2 and the level 3, and we are going to hear about the community health units. The level 5 and the level 6 facilities are not included in the primary healthcare network, as they are designed to offer more specialized care. In this primary care network, we have a multidisciplinary team led by a family physician, and this is where us as healthcare professionals are in the multidisciplinary team. I will outline the roles of the multidisciplinary team. This primary care network is supported in the Primary Healthcare Act in Section 2 of the Act. So the governing structure of the primary care network in the counties, we know that we have the CC of health, we have the chief officer, the county the director of health, the sub-county MOH, and this is how the governing structure of the primary care network looks like. At the national level, we do have advisory boards, that is the Primary Healthcare Advisory Committee, which also each county should have at a county level. Also, they need to have a primary healthcare technical working group. There's a primary healthcare coordinator in every county who coordinates all the primary healthcare activities. We have a primary care network coordinator. It can be a family physician or anyone trained in family medicine. So a multidisciplinary team, as I'd mentioned before, it is led by a family physician, and this is where our role as a healthcare professional comes in. We have the medical officer, clinical officer, nursing officer, nutritionist, lab personnel, public health officer, pharmacy personnel, the community health assistant. I didn't mention before, but a community health assistant is a healthcare worker trained to provide healthcare services. We have the HRIOs, the health promotion officers, mental health officers, medical social worker, rehab, and AP logistician. Of note is the team is not static, and members can be co-opted to the team on a need-to-need basis. Some of the roles of the multidisciplinary team include overseeing the maintenance and managing of the population data for the PCN, ensure effective upward and downward referral of patients and services. So the referrals is not just from the community to the health facilities, it's also from the health facilities back to the community. The multidisciplinary team needs to support outreaches to the community. They need to do regular and periodic planned screening for health problems in the community. They need to manage medical supplies in the primary care network and the community. As we know, the community health promoters have been given kits, and some of these kits have medicines. They are not healthcare professionals, but with the help of the multidisciplinary team, who are the healthcare professionals, they'll be able to manage some of these commodities. The multidisciplinary team is to ensure continuity of care within the primary care network. That's why I said about the upward and downward referral of patients. They need to give health education to the communities. They need to conduct nutritional assessment and counseling, support networking of shared service delivery and resources. They need to support the referral services within the primary care network, supervise, train, and mentor other healthcare workers in the spokes, which I mentioned are our level 2 and level 3 facilities and the community health units. They need to monitor and evaluate services, and they need to also institute a fully equipped knowledge resource center at the level 1 for community education. Our community health promoters need to be capacity built. I know they have the blood pressure machines and they have the glucometers, which they do not know how to use. So this is where us, as the healthcare professionals in the multidisciplinary team, come and support the community health promoters. Steps in the establishment of the primary care network. What I need to mention is that we need to establish around 315 primary care networks in the whole country. That means one primary care network in each sub-county. And there's a process for establishing this. It includes sensitization of all the stakeholders, because this is the new way of delivery of services. This is not a program that is to start and end. This is how we are going to deliver services as a country, and there's a lot of sensitization that needs to be done. There should be establishment of governance and coordination of structures, including the selection and nomination of the multidisciplinary team. A baseline assessment should be conducted. County needs to present an implementation plan after the baseline assessment. The dissemination of this assessment needs to be done. Households needs to be mapped to the hubs. Of note is that all Kenyans need to be mapped and linked to a primary care network. The next step is registration of households, and that's why we have the community health promoters using the UHC system to register the households in their communities. Also, identification of the financing requirements to establish and to make the primary healthcare operational, and to set up monitoring and evaluating system for the primary care network. And these primary care networks, before we say they are fully established, they need to be gazetted by the CEC member of health in the various in the various counties. Why are we establishing the primary care networks, and why are we making them operational? This is because we are having a paradigm shift. The current state of healthcare is focused on the curative approach, and now we want to go to the preventive and promotive approach. We have noticed that there is non-comprehensive and vertical services. We want to make all the services comprehensive and integrative. There's
Apologies for the interruption, Dr. Oda.
Yeah.
I'm kindly asking if I can share the slides on your behalf.
Okay.
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 Yes, I hope you can see it from your end now.
Sure, thanks.
Right.
So why are we having this establishment of primary care networks? I had said that there is fragmented primary healthcare structures, and now we are shifting to primary care networks, and we are going to strengthen the service delivery at the level 4, which is the hub, the level 2 and the level 3 facilities, our spokes, and our level 1 facility, which is the community health unit. Again, also the current state is that we have an unsustainable financial support, and with this primary care network, we are going to have a resilient financial support. Next. Yes. So the government, as I mentioned earlier, it has priorities and it has 5 core pillars, and healthcare is one of the government's better priorities. Better is just bottom-up economic transformative agenda. Next. The better healthcare priorities, 1, they are to take care of the inadequate human resource, because it was noticed that healthcare delivery is not being done correctly because there is the human resource is not adequate, and the priorities are here to address that. We also, it is going to address effective supply chain of HPTs for commodities. We are seeing that the integrated health information system, it is now fragmented, and now we want to have the digital superhighway, where as a healthcare provider, if you see a patient today and I'm seeing a patient tomorrow, I don't need to start asking the patient about their history. I can just get the history and continue with the management of this patient. It is also going to address healthcare financing, primary healthcare, and community health interventions. Next. So towards achieving the better priorities, that is why we have the 4 acts that were assented into law last year. We have the FIF Act, the Primary Healthcare Act, which we are focusing on today, the Social Health Insurance Fund Act, and the Digitization Act. When you go through all these acts, you will notice that they are all focusing towards one direction, that is primary healthcare and making healthcare services to the people to be accessible and easily affordable. Next. The objective of the Primary Healthcare Act, 1, it is to promote and to fulfill the rights of all persons in Kenya. It is to promote the implementation of primary healthcare through a systemic approach and clear delineation of roles of all the stakeholders in order to achieve universal health coverage. It is to provide for the establishment of primary care networks, community health units, and to make sustainable primary healthcare services. It is to provide for the role of the multidisciplinary team, who are the healthcare providers, to be able to provide primary healthcare services to the community. Also to provide the role of the community health officers, community health assistants, and community health promoters in the provision of community-based primary healthcare. So all this, it is just to make sure that we are doing everything according to the law, and we are not just implementing things that are not supported by law. So that is the objective of the Primary Care Act. Next. Yes, primary healthcare, we like saying that this is people's happiness center, because we are making people happy by taking healthcare services close to them and making these healthcare services affordable to them. Next. So the references, you'll get all these from the Primary Healthcare Act 2023, the beta priorities 2022-2027, the Kenya Primary Healthcare Strategic Framework, and the Primary Healthcare Network Guidelines. Thank you. Back to you, Phyllis.
Thank you, Dr. Oda. Thank you very much. There are quite a number of questions in the chat. I will read them out and I will ask our next presenter, Dr. Salim Hussein, who's the head of Primary Healthcare Division at the Ministry of Health, to make his presentation with these questions in mind as he talks to us about the ministry's vision for primary healthcare in Kenya. So there are questions that have been asked. One of them is about the health resource for healthcare, or human resource for healthcare. And Dr. Oda mentioned that there's inadequacy, and that's true across all cadres, from community health promoters through nurses, medical officers, specialists. There are few in Kenya. So there's a question asking, why are we focusing on sending healthcare workers abroad rather than keeping them while we have a shortage? There are also questions about other things that people have noticed is missing from primary healthcare network and community health. The one that has been mentioned most is dental and oral care. So if it's there, you can let us know, or if it's an oversight. The questions are asking if that can be added in. And then there's a question on community health workers. There's a lot of concerns about therapeutic or rather administering medication of simple ailments. And questions are, for example, diabetes is really not considered simple. Malaria, depending on how severe it is not considered simple. So there are a lot of concerns about how far community healthcare workers can go safely in administering medication. Dr. Salim, welcome. And thank you all the 900 of you who are still with us in this conversation. Welcome, Dr. Salim.
Thank you, Phyllis. Good evening, everyone. Thank you very much for giving me this opportunity. I also want to appreciate my former panelists for what they have done, what they've described, especially Kennedy. I think from the community ground, what is really happening on the grassroots, I think that was quite an eye opener at some of the challenges that he had mentioned. I think my work has been made very easy by the former presenters. I think they have taken us through the practical aspect. They act quite well by Dr. Maureen and Dr. Oda, and also some of the things that we're doing. I just want, before I go to some of the questions, to put across that some of the functional mandate of this act actually is to improve preventive and promotive health services, to have these services also being paid by the government, despite that they're free for the people. And I think it is good to note that in the object of the Primary Healthcare Act that Dr. Oda mentioned, actually the first one is to fulfill the right of all in Kenya. I'm glad it is all in Kenya, not just Kenyans. So it also brings about the integration and the comprehensiveness of services, avoiding the vertical silo programming that we have been having, especially if you look at the HIV, TB, and malaria. There is increased coordination between the different levels, especially from level 1 to level 4. We are aiming at sustainable financing, which Oda clearly and put it correctly, so that we can have sustainable financing. And then more importantly, is to take the services closer to the people so that we can have more of outreaches. We can have the multidisciplinary team working together, taking services to the grassroots, wherever they can. The health workers, different cadres, organize with the lower level so that they can take the service there instead of all the clients coming up. Yes, we still have a shortage of human resource. That one is one of the issues that the beta priorities is coming to address, and it's also one of the UHC pillars. More importantly, I just want to put it across that our ministry vision for PHC is actually using PHC as the approach to achieve UHC. And if you look at the principles of PHC and the UHC, basically they very much align to each other. The issue of giving accessible, universal services which are respecting the custom, the way of doing of those people with their engagement at a cost and where they need it. That is primary health. And actually that it has been shown and there's evidence it supports, and those who have almost or gotten to UHC, this is the most cost-effective way that they can actually get to UHC. We still have a gap, according to WHO standards for for health workers for population ratio, which is actually 4.5 to 1,000. Kenya is still at about 1.38, so we still have a long way to go. Yes, I know one of the participants clearly stated that we are taking or we are allowing some of our health workers to go abroad. Yeah, we still have a gap, and I think this is something that all of us we should try come together and address so that we can have at least to almost the needed required or standard. So there's still a gap, almost more than half of the gap that we need. I think some of the other things that has been mentioned at the community health level, which will have been better tackled by Dr. Maureen, but which I will try and address. One, the kit, some of the medication that it has is albendazole, paracetamol, there is zinc and ORS. There are no other medication in this kit. So most of the other elements actually are supposed to be managed at the higher level. The CHPs are supposed to refer. Most of the conditions that we have mentioned, which is TB, malaria, they'll be doing a lot of preventive, promotive health. The paracetamol that is there, especially for the children, is a first aid sort of thing to be given. Children who have a high fever and then they are referred. So basically, there'll be very little of any medication that will be being distributed or being given to the community by the community health promoters. I'm assuming those are the questions I was to address, unless there's any other thing. I think for me, this act gives us now a legal mandate to promote primary health care. It enables some of the cadres to work within the legal framework, but more importantly, it really emphasizes integrative, comprehensive, and multidisciplinary type of approach, which is essential, especially looking at our system. When you look at our building blocks from human resource, finances, the health products, commodities, there is a lot of gap. During the last assessment that we did, there's still gaps here. But we believe with the legal mandate that we've been given with this Primary Health Act, if the different levels, different sectors, different cadres, health workers work together, we are better off than when we are not working together. So I think for me, I'm a proud Kenyan that the way we have taken, most of the countries have not done the same. We have already seen some of the impact of this primary healthcare networks in the counties that they're being implemented. For example, in Lamu, Garissa, where in some of the health centers for the first time, the services that have never been taken there, now they have been taken to the lower levels. So I think we are seeing some positive changes. There are still other things that we might need to address, but I think it's a good start, and we all need to focus so that we can improve on the system together towards achieving UHC. Thank you. Over to you back, Phyllis.
Thank you, Daktari. Two more questions for you that have come up. What's the role of the private sector in primary healthcare as envisioned in the Act? And would you also speak to the oral health aspect, if it's something that, if it has been included in the Primary Healthcare Act and in the primary healthcare networks? This is for both you and Dr. Oda. You may weigh, both of you can weigh in. Currently, health is a devolved function, and the Primary Healthcare Act, in its implementation, looks like it would benefit from a centralized sort of implementation. So how is the Ministry of Health looking to implement it? Is it hoping, for example, goodwill from the counties, from the governors, from the CECs to be implemented? How is the ministry going to ensure that this is implemented and people from different counties, like if you're in Mombasa County and another person is in Homa Bay County, that you have access to the same care when it comes to the primary healthcare model, and same to the CHPs that Mr. Monde had spoken about remuneration. How is uniformity in implementation going to be done? Thank you.
Okay, I think in terms of remuneration, there is an inter-party agreement that we have agreed between the national level and the county that will be giving the CHPs 5,000. There are mechanisms that we are still talking also to Treasury so that we can see that it is smooth and that the payment goes to the CHPs, which is 5,200, 500 from the national. For the next 5 years, the Treasury, the national government has pledged to do the same. We expect the counties to give the other 2,500. We are glad that currently several counties had already started, but at different ranges from 1,000 to 4,000. So we'll be working together to see that that payment is being done. The act clearly, as Dr. Oda, when he was stating the object number 2, talks about it is a stakeholder-centered act that puts the private faith-based community as part of the managing committees in the primary healthcare networks so that they're brought on board and they play a crucial role in the management of these PCNs. I think those are the ones I remember in terms of the questions. Maybe Dr. Oda can pick the rest. Thank you.
Okay. The ones that are remaining are oral health, if that's part of it, part of the primary health care. Just a clarification.
The Primary Health Act does not enumerate any diseases or any condition. It provides an infrastructure for all the programs to be worked on. It is this UHC package that brings on board oral health, dental health. So basically, more of the primary health care, it will not be aligning which diseases should be done, but giving an infrastructure for all the cadres to bring on the programs to work within a standardized structure, which gives some of the guidelines on how they should be done. I think the other thing, it was something to do, how will we ensure whether it is equality or equity? I think more importantly, in terms of services, the documents for us are very clear, but we need to work all of us from the community, the health workers at the national level. We have a mandate of seeing that the standards are being done, but this is not something we can do alone. The communities also have to hold accountable their counties, what should be done, especially according to what the documents that we have disseminated, all of us. So I think it is a collective responsibility. Thank you.
All right. Thank you. Dr. Oda, any thoughts on the counties and how they can work with the Ministry of Health to ensure uniformity in implementation?
Yes, so we know the mandate of the Ministry of Health, which is to create the policies, and all the panelists have actually mentioned we do have the policies from the Kenya Community Strategy, Kenya Community Policy, the Primary Care Network Guidelines and Policy, and now we have the Primary Healthcare Act. So that is one of the ways that this is going to be made uniform, and all the programs are actually included. We are not segregating any cadre. The cohorts, rehabilitation, everyone is included in the primary care network. We are just refining how we are giving services to the people. And yes, the private sector is also included in this, because we know the number of health facilities, the private versus public. So we need to work together so that we can ensure that we are providing quality services to the people. It is close to them and it is also affordable to them. That is how the counties are actually working with the Ministry of Health to ensure this. Thank you, Dr.
Thank you, Dr.
Thank
Oda. Just to add that the multidisciplinary team, whatever it is, the guideline, it is suggested, and you can co-opt any other cadre. Whatever is there is not cast in stone. And the multidisciplinary team, when we are doing the trainings for the PCN, we are advising the counties, the sub-counties, that actually it should address the priorities and needs. So the composition actually should be depending on what
Dr. You're muted. Okay. I think we've come to the end of our discussion. Thank you everyone for attending. Thank you, Mr. Mondi. Thank you, Dr. Oda, Dr. Salim, Dr. Maureen, and Keme and Kenech for putting together this meeting. I'm reminding you again to attend next week on Monday, same time, the Facility Improvement Fund discussion, which is going to be very interesting on how facilities are able to manage the finances that they bring in. Thank you, everyone, and I hope from here we are all going to be better ambassadors for primary healthcare and be geared towards promotive and preventive medicine. Thank you, everyone. Good night.
Thank you. Good night.
Thank you.
Thank you very much.